what you can see here is the MRI scan and the CT scan of the same patient. And you can see here, this isn't quite midline, so we've moved out to the level of the foramen, but what you can see here is the pars defect.
Yes.
Now, I didn't need a CT scan to tell that there's a pars defect there. You could tell because you can see there's a discontinuity in the pars on this slice.
Whenever I look at MRIs, that's a nice clear one where everything's lined up nicely. There's no bend in the spine or anything like that. I always find it really difficult to see that clarity, to find the pars, because it all gets very murky and blurry, I find.
It can do, and especially if the patients have a degenerative scoliosis. So as you say, that if it's curvy, things aren't necessarily in the same plane. So what I do in those situations is I work with my radiologists, and we can use slightly different sequences of MRI scan that can look at the foramen better.
Right.
In the lumbar spine, I've not found the need to do that too much, but certainly in the cervical spine, the imaging of the foramen is notoriously difficult.
Right.
So you can see here there's a pars defect. So what will be associated with that is a small spondylolisthesis, so a small slip forward. And the way I think about this again, because the facets are no longer doing their job, more force is going through the disc. The disc over a period of time can then fail. You get a loss of disc height, and you get a spondylolisthesis, so the bone slips forward. The reason I get a scan is because, remember, I'm a surgeon, so a part of my diagnostic, one of the end results of the diagnostic workup is to offer surgery. Not always, but to offer surgery. And in this case, this patient had severe bilateral L5 pain, and you do a CT scan to determine the operation, the best operation that you can do. And in this case,
I mean, that is a very, very clear image of a pars defect, though, isn't it?
Yeah.
There's a big lump sticking, independent of everything else. And I should just point out that we're looking here at L5S1 there, aren't we?
yes.
And while you were pointing, this was full screen, so the audience couldn't see you pointing. So we might have to try your pointer and see if that little bubble will come up again. It's not playing the game. Just double tap it and see if it changes to anything. No, and again. No, we've lost it. So I'm sorry, we can't get the pointer to. There, it's on that screen. So it's now there. It is. It's just coming in from the right-hand side. We got it.
There we go. So yeah, we're looking at the lumbar sacral spine in the sagittal plane, and you can see beautifully the pars defect there. You can see that the facets can no longer do their job of restricting movement in the spine. The other thing that you can see, and this is one of the reasons to do the CT scan, is because there's often a bony osteophyte. Remember, this is a degenerative process that's happening over years usually. So there are reactive changes in the disc and the bone, and there's a bony osteophyte often in the foramen. And if you
is that what we're looking at here? That little
speck of white there is the start of one. Yes. And if you simply decompress that by putting an artificial disc, and I don't do artificial discs, I mean a cage, a fusion cage, in the disc space, and the point of that would be to increase the height, the foraminal height, and allow fusion to occur. If you simply, so the foramen at the back will then be bigger, similar to the height above. But if you do that and don't appreciate that there's a bony spur within the foramen, you can crush the nerve and make the leg pain worse. So CT scan gives you a better understanding of the bony anatomy, and I use it in all patients with this kind of pathology as part of the surgical workup, if we're going to go have surgery.